Hello, my name is Dr. Cynthia Magro. I'm the Director of Dermatopathology for Weill Cornell Medicine. Welcome to our interesting case presentation series. So today we'll be considering a 79-year-old male who has a history of congestive heart failure, schizoaffective disorder, recurrent pancreatitis, and recently was diagnosed with pancreatic adenocarcinoma, specifically an actinic cell carcinoma. He was admitted to New York Presbyterian Hospital with acute recurrent pancreatitis and was found to have an elevated lipase of 3,500. At the time of his admission, he had also developed painful erythematous nodules. And here we have a collage of his skin eruption. A biopsy was performed. It is a punch biopsy that extends into fat. The skin is relatively unremarkable, but there is clearly an abnormal process occurring in the fat compatible with some type of panniculitis. This is a higher magnification showing the process within the fat lobule. There is striking neutrophilia, but in addition there is a distinct pattern of adipocyte injury whereby the architecture of the adipocytes is retained. However, the cells are truly mummified, they're anucleated, and the cytoplasm has acquired this amorphous to granular eosinophilic and somewhat amphiphilic quality. It is a distinct pattern of fat necrosis that we refer to as enzymatic fat necrosis, and it is highly characteristic and unique to a particular form of lobular panniculitis, which is, of course, pancreatic panniculitis. And this is a higher magnification showing that distinctive enzymatic fat necrosis that is diagnostic of pancreatic panniculitis. Once again, you have the retained cytoplasmic membrane of the adipocyte, but the adipocyte is necrotic. There is no discernible viable nucleus. The cytoplasm has this eosinophilic to amphiphilic quality. Pancreatic panniculitis, from a clinical perspective, presents as tender erythematous nodules involving the upper and lower extremities and trunk. These patients oftentimes will have an elevation in the serum amylase and lipase. It is a unique type of panniculitis in that it is associated with pancreatic disease, where the pancreatic disease is essentially causal of the panniculitis. Most notably, chronic alcoholic pancreatitis is perhaps the most common etiology. However, it is important to note that pancreatic panniculitis can be a paraneoplastic syndrome in the setting of a unique enzyme elaborating adenocarcinoma of the pancreas, referred to as an actinic cell carcinoma. This is another case of pancreatic panniculitis we had a few years ago. Very similar presentation to this current case. This patient had multiple erythematous painful nodules, and he too was discovered to have an actinic cell carcinoma of the pancreas, making it another case of paraneoplastic pancreatic panniculitis. An interesting aspect of the clinical presentation is also one that encompasses polysericitis. They can develop an arthritis, and so why do they develop an arthritis? The actual enzymatic fat necrosis can occur throughout the body, and in fact can develop in the synovial fat as the etiologic basis of the arthritis that can be a very characteristic finding in patients with pancreatic panniculitis. They also develop peripheral blood eosinophilia, especially malignancy-associated cases, and a leukemoid reaction. So what is the pathophysiology? Well, certainly trypsin of pancreatic derivation is key because it enhances the vasopermeability to allow the lipase and amylase from the pancreas to enter into the body's peripheral circulation, causing fat necrosis and lipolysis outside the abdomen. in the skin, for example, specifically the subcutis, and as I was mentioning, within the synovium. Sometimes patients can actually develop bone pain because this fat necrosis affects the bone marrow, albeit uncommonly. In terms of the histopathology, I think this case certainly is a classic example of pancreatic panniculitis. It is considered a type of lobular panniculitis. The incipient expression of it from a morphologic perspective would be the ghost-like adipocytes, those mummified adipocytes that I showed you. And of course, anytime you have any type of cellular injury that is that can induce a secondary inflammatory cell infiltrate. So it is not uncommon in pancreatic panniculitis to see a significant influx of other inflammatory cell elements, specifically neutrophils. And this is a collage of images of pancreatic panniculitis, and you can see the characteristic enzymatic fat necrosis, these anucleated, mummified, ghost-like remnants of adipocytes devoid of nuclei, where the cytoplasm acquires this amorphous to granular eosinophilic and amphiphilic quality, although they're actually areas of frank basophilia. And why does that basophilia happen? Well, remember, the lipase that is released from the pancreas goes into the adipocyte and causes enzymatic digestion of the triglycerides into fatty acids. The fatty acids will then bind with the intracellular calcium to result in saponification. So the actual basophilic quality that you can see in the adipocytes reflects calcium salts, essentially, a saponification of the fat. And this is another higher magnification showing the anucleated ghost-like remnants of the adipocytes characteristic for enzymatic fat necrosis. Well, there are other types of fat necrosis in the subcutis, most notably lipomembranous fat necrosis. And in lipomembranous fat necrosis, one typically sees this fern-like deformation of the adipocyte that can be highlighted by PAS stain, and it usually reflects an ischemic microenvironment of diverse etiology. For example, lipomembranous fat necrosis is characteristically seen in patients with lipodermatosclerosis, for which one potential etiology is vascular insufficiency related to venous insufficiency, but really a number of microvascular syndromes that cause ischemia can eventuate in this pattern of insidious lipomembranous fat necrosis. For example, calciphylaxis can frequently have this particular finding. In terms of classic fat necrosis, well, there you get frank adipocyte injury leading to adipocyte dropout, whereby the released lipid results in an influx of macrophages that then imbibe the lipid. So in classic fat necrosis, you see this pattern of lipophage accumulation within the fat. And the fat necrosis can be due to an exogenous event, specifically traumatic fat necrosis, but it can also be endogenous. For example, patients who have an auto-inflammatory type of panniculitis, referred to as lipophagic panniculitis, develop a cellular immune reaction targeting adipocytes that can lead to this pattern of classical fat necrosis with this influx of lipophages. So to summarize then, pancreatic panniculitis is characterized by tender erythematous nodules on the extremities and trunk. There is concurrent pancreatic disease, be it in the context of an inflammatory process, i.e. pancreatitis, or reflective of a malignancy, specifically a cynic cell carcinoma. And the etiology is related to the enzymatic leak into the circulation, resulting in enzymatic fat necrosis, most commonly in the subcutis, but potentially in other organ systems. And obviously the treatment focuses on the pancreatic disease. And I'd like to thank our outstanding pathology resident, Dr. Arif, who helped me with this presentation. He was on a 2-week rotation in dermatopathology. He will be going into GI pathology, and I think he found this case very interesting. So I do thank him. Thank you for your attention.